How many times have you heard in the last few years of someone overdosing on drugs? I mean, I feel like it's every year that you hear someone famous, a celebrity, who's passed away of a tragic overdose or even an accidental overdose. It's really sad, you know. And remember when we were kids, when we had Scruff McGruff, I think it was, and he told us, hey kids, don't do drugs. And remember, he always used to say,
now, what are you gonna say if someone asks you to try drugs?
Hey, I don't need drugs because they can make me goofy.
I mean, drugs have to be bad for you, right? They harm people, they hurt people, people overdose on them. Drugs can't be good for you, can they? And then also think about this. The elderly get elderly abuse and taking so many different meds from different doctors. The cardiologist is talking to the oncologist, and the oncologist doesn't know what the PCP sent over. And there's all these medications. So there's no way that medications can be good for you, right? With everything, there's good and bad. But there are some good things regarding drugs, specifically controlled substances, that can be good for hospice and end of life, that can actually help the process. Let's talk about it real quickly. One of the biggest hot topics in hospice or home health is drug use. When it comes to drug use, how do you control drugs? What type of drugs do you use to help with patients who are in pain or anxiety at end of life? Those questions are so many questions that we get asked a lot. So this podcast, me and my wife, again, decided to walk through what are the top most common drugs that you usually hear at end of life. What are they for and how can they be used? And how should they be used at end of life? If you're questioning about medications specifically like morphine or what comfort kits are, this podcast is for you. So enjoy this podcast. You can always click through the chapters to fast forward or to figure out specifically what you want to listen to. So I hope you enjoy this podcast with myself and my wife, Emilynn. Let's go. Woo! How's it going?
It's pretty good. Here again.
Hey, let's go. Hope you guys are doing good. We're going to chat today about a few things, but I think one of the things that we were thinking about was questions that we get all the time regarding medications and comfort kits and morphine.
Ooh, that's a touchy subject.
Yeah, and end of life medications and how are they used and what are they used for and why and how the heck does, can I say heck?
Yeah, I
Okay.
think it's appropriate.
How the heck does hospice cover medications? Like, what does that even look like? Like, you know, how does that process work? You know, so I think
it's important first to give the caveat to our people that are watching to know that every hospice has different policies.
Yeah, true.
Every hospice
True.
has different processes and procedures and prescriptions, and some of the medications I might talk about could be very different or look different, but they're all treating relatively the same thing.
Let's go into specifics. So, like, let's talk about different categories or the top 5 medications that hospice companies use or hospice agencies use and why. What would you see, like, when you look at patients, you always usually see these type of common medications and why?
I see medications for hypertension all the time.
Cool.
That's a huge one. Hypertension or tachycardia, cardiac meds, basically. Most of those are covered by a hospice. Generally, if a patient is on any cardiac meds, we don't stop them because they could rush the patient's death. They could be at risk for a stroke or a heart attack or whatever else have you. And so a lot of heart medications are frequently seen. I see thyroid medications a lot. That's not a hospice medication though. It's not considered something that if we stop it, it will rush the death process. Yes, they may have some discomfort or side effects or whatever, but usually we keep it on as long as they can tolerate medications. Anything for pain. Okay. Pain's a big one.
Yeah.
So hospice covers anything that's related to your comfort, whether that's your pain, your bowels, your diuretics, anxiety, depression, all of those medications are all
They come together.
Mm-hmm.
Do you ever see patients that are on like a lot of drugs and then when hospice comes in, they come in and kind of reconcile and review all those drugs, and you see them actually kind of get better.
That is a huge benefit of hospice. Yeah. Yes. So polypharmacy is a huge issue in our country, because we have so many doctors and so many specialists and everything else. It's so common for us to one doctor to prescribe some XYZ, and then another doctor or another specialist to provide ABC, and then those two doctors don't talk to each other because they're in different networks or different whatever, and they don't see all those meds. That's the main reason why any doctor you go see asks for your med list, because it gives them an idea. But if there's 2 or 3 meds that are newer or aren't on your med list, they don't know. They might not recognize, oh, that's a bad idea to interact with another one. It is so common for us to have 6 different specialists, and all those different specialists are prescribing different things. And so a lot of times our hospice comes in, one doctor and one nurse is looking at one med list that's comprehensive of all these specialists. That doctor has is usually an internal medicine or a geriatric doctor. They can say, well, these 2 are probably interacting negatively with that. But also it's a big thing too, because we talk about like vitamins, like supplements are important. Yes. Cholesterol medications are important, but at this stage of life, are they really benefiting your loved one? What is the pro versus con of them? Is their body digesting those properly? And we go through all of those things. So it's super beneficial to have our hospice doctor look at the med list and kind of do a once over. Our policy is to just make recommendations, and then the family can decide. And then I make it very clear, like whatever you decide to keep that the hospice doesn't recommend, continuing, we won't provide those medications. So sometimes that can cause a little bit of like, oh, you're messing up our process. I do the pill box Mondays every week, blah, blah, blah. That's where we always say, let me help you with the pill box. I'll do the med refills. I can even call your CVS and order the refills, whatever else.
Are there any medications that hospice is like doesn't cover that are kind of like controversial medications?
Blood thinners are a big one.
Okay. Why?
Blood thinners are a big one because generally when our patients are on hospice, they're end stage heart failure. And so if their INRs or their PTs are really, really high, they're at such high risk for internal bleeding. When you come on hospice, we're not doing imaging, we're not doing testing, we're not doing lab draws as frequently as your cardiologist might be used to doing them. So it's a risk for you to be on them. Not to mention when you're on hospice, generally you are a higher fall risk. If you were to fall and you're on warfarin or Coumadin or Eliquis or any of those really expensive blood thinners, it's a big risk that you could even hit your elbow and internally bleed all in your elbow or wherever else. I mean, you just don't heal as quickly. Generally, those patients' nutrition and their body is just not filtering like it should be.
Is there a reason why a family wouldn't want to stop like Eliquis or warfarin or things like that? In your experience, like, is there reasons why?
Generally, we recommend to stop a blood thinner and use a safer blood thinner, such as aspirin. Yes, aspirin is not as strong, but it's an effective blood thinner in the sense of it's still going to keep you anticoagulated, essentially. The beautiful thing about aspirin is it's safer because it does allow your blood to thicken a little bit so that it's not so thin and so viscous that, if you were to fall, it's just safer. The other thing is it doesn't require that weekly monitoring. So with warfarin or Eliquis, you do have to have regular lab draws and regular blood or finger sticks to check your PT-INR. You don't have to do any of that monitoring with aspirin, so it is safer. It's also a cheaper option for sure. So that's a huge benefit to our medical system as a whole.
100%. Well, so if I didn't know what PT-INR is, like what is PT-INR? What is that? What's an INR reading?
So a normal INR is between 2 and 3. Generally, if your INR is higher, it means your blood is too thin. If your INR is lower, it means it's too thick. So it is
viscous.
It's very challenging to keep it in that range. And so a lot of times, like our very advanced heart failure patients go to a heart failure clinic before they come on hospice, and they're checking their INR weekly. So if they're on a warfarin or a Coumadin or a Eliquis or whatever else have you, they're checking their lab draws weekly. The doctor may adjust or tell them to hold their warfarin for 3 days, depending on what their INR is.
Right.
But on hospice, the other reason why we encourage people to go to a safer blood thinner is because it gets really challenging to monitor that and keep you within a therapeutic range. That is the biggest challenge.
Gotcha. And your body is already declining.
It is. The heart's just not working like it should.
Yeah, that makes sense. So those are kind of the top, kind of...
Those are the ones we see most frequently, but I will say every area of the country sees different things. Right.
Let's talk about different categories of drugs in terms of how it addresses patients where they're at in their disease process. So let's talk about like the most common medications that hospices use for anxiety, or what are some of those, or any other drugs for anxiety and depression for patients?
We like to use the safer ones. The problem with the anxiety and the depression medications, a lot of times starting them, is it's pretty common for our patients to be depressed at end of life. But the problem with a lot of those anxiolytics or SSRIs is that those categories of drugs generally take time to get in your system and build up, right? So sometimes we don't have that time, and so sometimes we're ending up using more faster acting or as needed medications that might not last as long, basically. Gotcha. So if we're just talking anxiety in general, lorazepam, Ativan, and then Xanax or alprazolam, those are our two really big go-tos. There are other drugs like Valium or diazepam that you can use as well too. There's just a lot of anxiolytics out there, and the biggest reason we use anxiety is because people have anxiety about dying. People have anxiety about their body shutting down or the death process. How is it going to happen? Is it going to be fast? Is it going to be painful? Our families have anxiety about the death process, and so that's a very real thing. Restlessness, or we have a term that we use frequently that's called terminal agitation. That near the end of life, especially our dementia patients, there is just no amount of medication, no change in their antipsychotics that can help them. They really need to be heavily medicated with anxiolytics like Valium or Xanax or lorazepam in order to stay calm, to allow their body to go through that dying process. But usually that's a last resort thing, and generally those meds are very closely monitored. So
I remember, I was thinking about, you just reminded me of a patient that we had like years ago that like run on admission, terminal diagnosis, run on admission was like, no morphine. I don't want any morphine. Whatever happens to me, I don't want morphine. So I took time and chatted with him just to get to know him, and he was a painter, like a really good oil painter, and he told me, he said, the reason why I don't want to take morphine is because he used to, I forget the name, but he used to follow a famous French painter who died of a morphine overdose. And he was like, I'm not ever going to use morphine. And so I was like, well, that makes sense. Like, yeah, like, but did someone educate you on what morphine is used for at end of life and how it is actually made to help through the end of life? And so I think we get that a lot, right? I think with anything, fear comes with a lack of knowledge, right? And so when you don't know something, you're going to fear because you're going to assume, right? So what is the purpose of morphine when it comes to patients at end of life?
So first of all, I want to address the elephant in the room.
Where is it?
Morphine
Where's the elephant?
Morphine's one of those really big drugs that people just assume that, like, you hear all the time people go on hospice and then they started the morphine drip and they died, right?
Yeah.
So that's a common misconception that morphine makes you die, or people think like morphine is like euthanasia, right? Like they think that's the only thing you can think of to compare it. But morphine.
And there's been some pretty bad cases, like just in Dallas.
There's been a lot of people abusing it. Yes.
That are hospice.
Yes.
Unfortunately.
Yes. And so I think it really does get a bad rap, but I think the morphine is used very specifically for pain or shortness of breath.
Okay.
So very frequently in the dying process, you have to think about it from head to toe, one body system at a time is shutting down, right? And not in order, not like, oh, I can tell his feet are going, I can tell his arms are going, you know what I mean? But like, there are body systems that are slowing down. Maybe the kidneys go first and they stop urinating. Maybe the lungs give out and, it's extremely hard for them to breathe. Maybe the heart is giving out and it cannot produce that oxygenated blood. And so their feet are getting blue, all the things, right? As one body system after another is shutting down to do the dying process, sometimes that is painful. It's anxiety causing, depending on how alert and oriented your loved one is. It's not normal. Shocking. It's not normal.
It's not normal to them. Like, imagine using your body for all of your life, and then all of a sudden you're not able to use a part of your body.
Yeah. So it's scary, and so we use medications to help with the anxiety piece of that. But as parts of the cardiovascular and respiratory systems are shutting down, one may compensate for the other, and as a result, shortness of breath is very common. So if you and I tried breathing 40 times a minute, that's very uncomfortable for a long period of time. It's very uncomfortable for a long period of time.
Yeah.
Pain is something that a lot of times we use nonverbal cues to measure. So if they're grimacing, if they're clenching their arms, if they're the vitals do adjust quite frequently at the end of life. So sometimes the blood pressure will go really, really high and then it'll just drop. Sometimes the heart rate generally is going really, really fast until right before death. Sometimes the blood pressure is steadily dropping and dropping and dropping and dropping and dropping, and we know that death is close. Usually days to hours before death, we cannot get a blood pressure because it's just so low, the monitor doesn't even pick it up. So a lot of times, like I said, while all those body systems are slowing down, there is those side effects of pain or shortness of breath. Those beautiful scenes in movies where people just die in their sleep. Gosh, I would love that for all of our patients.
It doesn't always happen.
But sometimes it doesn't happen for all our patients. And a lot of times, even when patients go into a cardiac arrest or have a heart attack and then that causes their death, usually that's a split second or that's a matter of minutes. And they're here one day and gone the next. And all of us as a hospice team are looking at each other like, what happened? But in those other cases, and in diseases like Parkinson's, Alzheimer's, congestive heart failure, those are sometimes our longer, more extended deaths that do need some of those medications to keep them comfortable, to keep them peaceful. And so there's a lot of education that we do at the end of life to explain why we need to keep them calm, because everybody wants a peaceful death for their loved one. So it's not to rush the death. Now, the big thing about morphine, and it's very important I say this, is that it is a respiratory depressant. So it is meant to slow down the respirations. Now, there's a very delicate balance of giving too much morphine to slow down the respiration so much that they're not breathing at all.
What's too much morphine? That's a great question, because I think we'll have family members that, of course, we have morphine dialed up for that in specific cases, and then the nurse will give and instruct them what to do. But sometimes they're like, how much is too much? All right, what is just a good gauge for families to know how much morphine is too much?
It really depends on the patient.
Perfect.
If the patient has been on heavy drugs or have had serious chronic pain issues, like they've been on methadone for years, they're going to go through morphine like water.
And it's not going to touch them too.
Yeah, because they have a higher tolerance for pain medication. And And we may need to use higher doses of morphine in order to keep them comfortable.
Right.
Other patients are 80 pounds and they've never had a lick of Tylenol in their entire life. Okay, they're only going to need the teeniest, tiniest bit.
Yeah.
So we give them a range. And granted, the nurse is very involved in what we call titrating medications to find the right dose. We always start small and go up.
Yeah.
So there are ways for us to monitor, was that dose effective? Was it not? Do we need to go up? Was that dose overly effective and they are just so sedated and lethargic? Okay, let's pull back.
Right.
And all of that has to do with assessment and behavior. And you really do need a nurse holding your hand through it because we are experts in understanding, okay, that was too much. We don't need to do that too much. Morphine liquid. So some hospices will use a morphine pump, like if you have a port, if you're a cancer patient and you have a port, some hospices will use a pump. We use liquid medication, so oral liquid is a very small amount that's dissolved into their salivary glands, and so usually we start small with just 0.25 and then we'll go up and up and up depending on what their needs are. How is their body handling these symptoms? And then again, it just depends on what the needs are. How is the patient handling it? Morphine liquid doesn't stay in your body as quick or as long. So it usually what we do is our dosage accounts for giving it as often as every hour. Now, the smallest amount every hour over a 24-hour period of time, people look at that and they think, oh my gosh, that's so much. In reality, it's not. I have other chronic pain patients who've had 2 full mils of morphine, which is 40 milligrams every hour for days because that's their chronic pain issue that they've been dealing with and they can't swallow their pills anymore. So that's a big problem. There are other medications that are not pills that we can use in combination with the morphine. But again, all of that has to be so very carefully titrated and used so that we're not over sedating a patient.
And I think that's why the relationship with the family and the nurse is so pivotal. And I think having, we talk about this all the time, but bedside manner, soft skills, taking the time to educate and address fears, right? Nurses have to be
Sherlock Holmes.
And they have to be able to say, like, if someone is yelling at you saying, no, I don't want morphine, there's probably a reason why they're saying that.
Yeah, for sure.
And that's the opportunity for you as a nurse to sit down and say, what's going on? Like, what experience did you have? Okay, I'm so sorry that you went through X, Y, Z. I'm so sorry about that. But for this situation, it's actually probably best that we do this. And taking the time to do that will save so much other effort, right? And I think nurses, and not just nurses, but any nurse practitioners, doctors, or anyone who's administering that specific medications, they have to take time to educate families.
People, usually it is digging deeper into the grief, into the past experiences. It's figuring out, okay, I get that you're scared of morphine. Tell me why. And explaining why that specific patient and this specific situation warrants the conversation about morphine. So once again, every hospice has their own policies and procedures. We don't like to put what we call a comfort kit in the home until the patient, we're seeing declines that are patterns of, okay, we might need this in the next week to days or whatever else have you. So a comfort kit is generally what we like to call like the nurse's toolbox, basically. So it's got medications. Generally it has morphine in it. Generally it has lorazepam in it or some sort of an anxiolytic. And then it has medications for nausea, vomiting. It has medications for secretions. So very frequently at the end of life, people have heard about the death rattle. It's because as the body is slowing down, as the lungs are shutting down, it can't process those secretions you and I carry every day.
Every day, yeah.
But we are standing upright, we are talking, we are coughing, we are eating, all of those things. The body has nowhere for it to go. So when they're laying in bed, they all just rattle around in here. It's not uncomfortable to the patient, but it's very hard.
It just sounds...
It's very hard for families to hear.
Yeah.
And so for that reason, we use a medication to help dry up those secretions. Now, there are side effects to that too. It's very drying to the mouth because that's the purpose of it.
Right.
So if a patient is alert, that may be very uncomfortable.
Right.
But that's another big one that we use. And then suppositories as well for like Tylenol is a big one because fevers are common at the end of life. The brain is not processing temperature like it should be. And so it's very common for our patients to have fevers at the end of life and during the dying process in those last
that's
couple
really
days.
important to I feel like families don't realize that too. It's like, whoa, what's happening? Like, is there an infection? No, it's your body is just shutting down.
Yeah, the brain is not processing temperature.
Yeah.
And then the other one is constipation suppository. It's because sometimes our patients get so impacted or constipated, generally right before they pass. This is the poop talk, poop emoji.
Yeah.
Generally, our patients get really impacted right before they pass away, whether it's a change in their diet or their medications have stopped up their bowels or whatever else have you, depending on how the body systems are shutting down, that sometimes, we have to use a suppository to help them release all of that so that they are more comfortable.
Yeah. And I think the crazy thing about it is that a lot of times, when they think of like the word comfort kit, right? It's if you really think about it, it's meant to comfort, right? So
each medication has a reason. It has a purpose.
Yes. And if families are educated on what each medication is actually meant for, it brings the family comfort.
Yes. Hopefully.
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 Yeah. That's great.
There are times when families will refuse medications or they'll refuse one or two of the medications, and they totally have the right to. I sadly have had patients who've passed away probably in pain, but that is the family's right. We are guests in their home. As long as I've done my job to educate and encourage that this is what is best and what is recommended, they do still have the right to refuse that. And that goes back to cultural barriers a lot of times.
Oh yeah, 100%. I think there's a lot, it's cultural barriers, it's beliefs, it's religious beliefs, it's everything you can think of. And so the hospice's job is to present the knowledge, right? And then the family has the right to choose or not to choose.
Absolutely.
At all times. But I think it's so important that the hospice understands that they're there to present with care, with tenderness. And it's also how you present it. You could be brash and rough and present something, or you could be very kind and considerate and present something, and someone will take it better.
Yeah.
I think those are things that we see like a lot. Any last kind of comments regarding medications for hospice, patients, for families, anything that you would like to kind of chime in on before we end this video?
I do think you should advocate for your loved one in the sense that if the medicines in the comfort kit make you uncomfortable, ask the hospice not to send them out until it's time for those medications. I think that every family has the right to decide what's right for them. They know their loved one the best. A lot of times facilities will ask us for a comfort kit early on and they just keep it locked up, and that's totally fine. We'd rather have tools in our toolbox than go out to a visit and not have anything to work with. That's frustrating to us as nurses. So it is very on the nous of the nurse to be able to know when it's time for that and time for that conversation. But I don't like to put those meds in people's homes until it's time, because it makes people feel uncomfortable. It also makes them feel like they've got a ticking time bomb in their back of their fridge. If there's little people in the home, that's always a risk or a hazard. So be safe with them, obviously. So yeah.
Yeah. Oh, this is actually really good. So I know that said that was the last thing, but I think it's important. Okay, let's talk about medication disposal, like really quickly.
That's an interesting topic.
So I think let's chat about just really quickly about how once a patient passes away, what's the medication disposal process? I know every hospice has their own policy, but generally we can talk about our policy and what we do.
Yeah.
But just in general, what is that, and what is it okay for the family to keep the medications and not dispose it? Let's talk about that whole process.
That's a touchy subject. So in Texas, we are not required to dispose of medications. As soon as the patient dies, the medications are technically the property of the medical power of attorney or the next of kin. Most facilities will ask us to dispose of those medications during the death visit. So my process is literally to destroy them, in the sense that I put them in a Ziploc bag, empty everything into it, count it, have a witness, and then I will cover it with just Dawn dish soap and then throw it away. The Dawn dish soap obviously destroys it enough that if anyone were to put their finger in there and try to take an oxycodone out, it's not gonna do anything. Yeah. So we dispose of it that way. Other people will put it into a diaper and cover it with soap, and then just throw the diaper away. Other people will put it in a bag with kitty litter and add a little bit of water. It clumps together, and then it's impossible to really separate. The FDA actually recently has released literature that it's okay to flush medications or pour them down the drain. I don't recommend this, but again, the FDA says it's okay to do, so that it is an option. And like I said, every hospice, every state has their own medication disposal policy, so it's best to ask your hospice what their policy is. They do have the right to refuse you disposing it. So what we do on death visits is we will ask, what would you like to do with your loved one's medications? And then if they do say we want to keep them, I would clearly document that all to cover us. If we dispose of it, any narcotics get counted and witnessed. And then sometimes families will say, oh, that's just Tylenol, I'll keep it, that's fine. Whatever else. So it's really the discretion of the nurse, the family, all that stuff. But as long as everything's documented, it is up to the family to decide what they want to do.
That's good. Awesome. That was great. Well, that's all we got for today. If you guys liked this information, this video podcast or chat that we're doing, please like and subscribe. Also, if you wanted to talk about other things, other topics regarding hospice care, palliative care, end of life, home health, we're going to do more home health stuff too. Please put in the comments, add some information in there. We will do our very best to respond and give you guys some good information. So hope you guys are doing well. Hope you enjoyed it. That's all we got.
God bless.
We out.
Peace out.
We out.
Let's hope it's recorded.
Oh, Lord.